So we'll move on to the next lecture. Dr. Shashi Apte is actually held up with some work. So we'll have a talk by Dr. Rajesh Patil. So he's going to, Dr. Rajesh Patil is a consultant hematologist and BMT physician. He has done his MD in general medicine, DM in clinical hematology, and fellowship in bone marrow transplant in CMC Vellore. At present, he is working in CTC PHO BMT Center as a consultant hematologist and BMT physician, and he's also consultant hematologist in Rukmini Hospital, Thane. He's going to talk on what is actually the present scenario we're facing. Is like a lot of patients we are having this COVID second wave. So he's going to talk on COVID-19 and COVID-19 vaccine from hemophilia perspective, because a lot of patients has got queries and they come always, and so it's easy for us to sort out the issues. Over to you, Dr. Rajesh.
Good afternoon, everyone. Thank you, organizers, for this opportunity to talk on COVID-19 and COVID-19 vaccine in hemophilia perspective. So, as we know, in the end of 2019, an epidemic which is focused in Wuhan part of China, and which is supposed to be came from the seafood market in China, has taken over all of the world and become a pandemic situation. We know that this infection spread from person to person from a respiratory droplet point of view, and the clinical presentation can be varied. It is mostly asymptomatic or can manifest as mild flu-like symptoms, and can become as severe to cause a severe form of interstitial pneumonia, or what we now know as a severe form of coagulopathy, causing in 15 to 20% severe coagulopathy causing death. So what this COVID pandemic has posed the challenges for the hemophilia community. So as Tulika Seth madam had said, that the access to hemophilia treatment, it is hampered because of the whatever the restriction which are posed because of this COVID-19 pandemic. The delivery of replacement therapies has been hampered. So in developed nations, though there is no problem regarding the availability, but because of the lockdown and manpower issues, while in the developing and poor countries, who mainly depend for the supply on the humanitarian basis of factor, the factor delivery was an issue, as well as the production of the recombinant DNA factors were issue because of the manpower and transport issues. While because of the shortage of the many plasma donors, the generation of plasma derived protein factors were delayed. And this lockdown has also given a significant impact on the regular medical follow-up and assessments and different consultations. As madam has said, that the specific therapies which are given to the hemophilias, like immune tolerance induction, they have severely hampered, and many centers are not able to provide such therapies, as well as many diagnostic procedures, many educational programs for the physicians, for the families, as not able to hold up. Many elective surgeries were postponed because of the COVID-19 pandemic, and pandemic has negatively impacted all the clinical research and the funding to the hemophilia worldwide. So coming to the COVID-19 per se effect in a hemophilia patient, in March 20, a first case of COVID-19 in a hemophilic was reported from China. That was a hemophilia with mild symptoms, which is managed with the IVIG infusion and the supportive care, and later on with full recovery. So at present, with the available evidences, there is no indication that the patients of hemophilia, those either on prophylaxis or either on on-demand basis, are at increased risks for the COVID-19 infection or at the increased risk of more severe COVID-19 disease. So the indications for hospitalization for hemophilics are the same as of other patients who don't have any other bleeding disorder. So what we should do when we get admitted for the COVID-19, at the admission counter and to the treating physician, we should inform regarding our disease, whatever bleeding disease it is, hemophilia or VWD, regardless of its severity. Diagnostic workup, which is more commonly done by the nasal swabs, That is no difference between this diagnostic workup for a person with hemophilia and another normal persons, and there is no hemostatic support required for these nasal swabs. Initial laboratory workup which is required for COVID-19 is more or less same for the other patients, which is like CRP, full blood count, renal function test, prothrombin time, APTT, fibrinogen, ferritin, D-dimer. For the patients with hemophilia, we can also do a inhibitor screening if there is no recent inhibitor reports are available, and those who have the availability of factor assay, we can get a factor levels also done. There is no difference in the indications of the chest imaging for a person with hemophilia. Only if the person is requiring invasive intervention like arterial blood gas analysis, we have to supplement the factors and keep the factors level more than 50% in such scenario. So as we can see, these are the common tests which are done at the admission for any COVID-19 patients. Prothrombin time, there is no difference in non-hemophilic versus hemophilic. APTT time, as we all know, it is prolonged in those patients with factor VIII and factor IX deficiency. And as Dr. Neeraj has rightly said, APTT will be short in those patients who are imicizumab, so we have to take this into the account. There is otherwise there is no difference between platelet count and fibrinogen. D-dimer, only those hemophilics who have a severe bleeding or those who are using bypassing agent will have a D-dimer elevated irrespective of their COVID-19 coagulopathy. So for those hemophilics which have a mild factor deficiency, as we know that this COVID-19 infection can lead to inflammatory response and lead to increase in the factor VIII levels. So there might be increase in the levels of factor VIII in the mild hemophilics, and before starting any therapy, if there is a facility available, they can get a factor VIII level checked. And as we already mentioned, that imicizumab will have a falsely normal or shortened APTT because of its mechanism. So regarding the thromboprophylaxis in COVID-19 patients who were PWH, is that here the concept of standard dose venous thromboembolism prophylaxis is like what we take as enoxaparin of 40 milligrams once a day. Escalated dose is like 1 mg per kg once a day, while therapeutic dose is 1 mg per kg twice a day. So as the COVID-19, it is more or less similar to as what are the COVID-19 guidelines. Outpatient department, there is no need to give generally any VT prophylaxis. It might be considered to case basis for those patients who are at high risk of thromboembolism, like those who have severe obesities, those who have history of thromboembolism or having active cancer. Otherwise, those patients who are ward, they generally receive a standard dose thromboprophylaxis. Those patients who are in ICUs, it is recommended that they should be on escalated dose VT prophylaxis, which is with enoxaparin 1 mg per kg once a day. While those who are there is confirmed diagnosis of venous thromboembolism or pulmonary embolism, or high likely chances of pulmonary embolism, those should go on therapeutic dose anticoagulation. And as they have written that ARDS might be a representation of a pulmonary microvascular thrombosis, escalated dose thromboprophylaxis can be considered in this scenario even without obvious evidence of thrombosis. So after discharge, while there is no specific data exist what to do after discharge, but it is reasonable to consider the extended thromboprophylaxis for those patients who has a high risk of thromboembolism with lower risk of bleeding. Like I said, those patients who are obese, those who have history of thromboembolism, who have active cancers, for them extended thromboprophylaxis can be considered for 3 to 4 weeks. So coming to the factor institution for these patients who are on thromboprophylaxis, as we already know that outpatient patient don't require any thromboprophylaxis, they can continue their factor VIII and factor IX substitution as their prophylaxis program. Those patients who are in wards and those who required a standard prophylaxis, which is enoxaparin 40 milligram once a day. For them, factor 8 level should be maintained more than 30% at trough, with avoiding peak more than 100%. A similar more than 30% factor should be maintained for those who are hemophilia B. Those patients who are in ICU or ARDS, for those patients, as we know, there is escalated dose or intermediate dose prophylaxis, which for enoxaparin comes with the 1 milligram per kg once a day, or maybe 60 milligram once a day. For them, the factor level should be maintained between 50 to 100% for factor 8 deficiency, while it should be 50 to 80% in factor 9, because as such, in those factor 9 deficiency patient, factor 8 level will be high because of the COVID per se coagulopathy. Those who have a proven pulmonary embolism or DVT will receive enoxaparin in therapeutic dose, which is for enoxaparin is 1 milligram per kg twice a day, with maintaining the factors level between 50 to 100% for the hemophilia A and 50 to 80% for hemophilia B. So for what to do for those patients who are on emicizumab? For the emicizumab ward patient who require a standard dose prophylaxis, there is no need to give additional factors. This is for those patients who are on emicizumab with hemophilia without inhibitors. Those who are in ICU requiring escalated or intermediate dose prophylaxis, for them additional factor 8 or factor 9 should be instituted. Those who have a proven pulmonary or deep vein thrombosis, them also require additional maintenance of factor level 50 to 80%. So what care we should do when this patient of hemophilia gets ICU admission? So it is recommended that their factors level should be maintained between 50 to 100%, as we saw that they will require a therapeutic or intermediate dose of thromboprophylaxis. And if possible, daily biological monitoring of their hemophilia replacement therapy should be done. So presence of severe arthropathy should always taken into account while positioning of the patient, as we know that prone position ventilation helps in the patient with the COVID-19 pneumonia. We should always look for the severe arthropathy and take care of that. Also, these patients are more prone for nerve compression during the positioning, so we should give adequate attention to that. For those who are critical, there is no contraindication for the ECMO, is extracorporeal membrane oxygenation, provided that we have maintained the levels around 80%. So a few slides regarding the COVID-19 vaccine. So as we all know that in December 2020, UK has first approved and started the vaccination, and in January 16, 2021, it has started in India. The rationale is the same, to provide the protection against the COVID-19. And how this COVID-19 vaccine works. It stimulates the immune system to produce the antibody against the virus, and it also helps for developing a memory lymphocytes or memory T cells, okay, which retains the memory and ability to fight off the virus if they get exposed. So COVID-19 vaccines, generally 3 types of vaccine. Like what we are administering to the patient, we can administer a protein component of virus against which there will be antibodies and immune response, or we can administer some genetic material like a mRNA, which will create an immune response, or we can use a vector vaccine, which is another weakened virus in which the protein of the COVID-19 virus has been introduced. So the Covishield, vaccine which is used of AstraZeneca, is a vector vaccine. Well, there is another vaccine which is Covaxin. Covaxin is a kind of killed vaccine. So at present, there is no particular reason to recommend one vaccine or the other for any bleeding disorder patient. The vector used in AstraZeneca is adenovirus. It is different from the AAV virus, which is used for the gene therapy of hemophilia, and it do not have a cross reactivity. So there is no particular preference for the vaccine for hemophilia patients. So while administering vaccines to PWH, vaccine should be administered intramuscularly with smallest gauge needle. and pressure should be applied for at least 10 to 15 minutes to that area, which reduces the bleeding and swelling. For additional 2 to 4 hours, we should inspect and palpate this area to notice whether there is a delayed hematoma or not. So those who are on regular prophylaxis, they preferably should take vaccine after taking their regular prophylaxis dose. Otherwise, those who are on on-demand basis, they can directly take a vaccine and just follow the precautions as mentioned earlier. Vaccination has not shown to prime factor 8 or factor 9 inhibitor formation. The mild hemophilics who have factor 8 level less than 10%, they might need a hemostatic treatment before vaccination. Those who are more than 10%, there is no need to give any factor. And definitely, as we come to know that those who are on imicizumab, there is no need to take an extra factor before vaccine. So those patients who have allergy or anaphylaxis to the blood products but not have any reaction to previous vaccine, they are not at any greater risk of COVID-19 vaccine. While those patients who has history of anaphylaxis or allergy to the PEG containing clotting factors, they should discuss with their physician that whether this vaccine they are opting for, whether it contains PEG or not. At present, the vaccine AstraZeneca vaccine do not contain PEG. The vaccine by Moderna and Pfizer, they do contain PEG. mRNA vaccines contain PEG. Thank you very much for this opportunity to discuss this topic.
Rajesh, thank you very much. Just before that, take the questions, I want to ask you, so you maintain a level during the while taking the vaccine of what, around 20%? What is the recommendation?
So madam, they are saying more than 10% is a good enough.
Okay, so we would sort of calculate at 10% to give.
Yes.
Before giving the vaccine.
Yeah.
Right.
Yeah.
We'll go on to the questions. The first question you have already answered. Somebody is asking whether the patient can take Covishield or Covaxin. You can take either. There is no preference. The next question is, this is a hemophilia patient who is on trial with concizumab, and he wants to know whether he can take a COVID vaccine and if there is any complication.
So regarding vaccine per se, actually there is no particular guidelines came for these newer therapies. So what they have advised that for the manufacturer, they can actually communicate for this, whether there is any component which contains any particular component for which there is contraindication or vaccine or not. Up to imicizumab and factors, there are the clear-cut guidelines there. For other therapies, they are advised to contact to the production like this or company who's supplying that.
Okay. The next, in the previous lectures, there was a question by somebody who said she's the factor 10 deficiency and can she take the vaccine? So I'll just answer it quickly. Yes, you can take the vaccine. Dr. Rajesh has already answered all the questions as to how the vaccine should be taken. The next question is, should one add low dose aspirin because COVID thrombosis can be both arterial and venous?
So if for asymptomatic patient, there is no role of any anticoagulation per se. Only those who requiring hospitalization should go on a prophylaxis, and antiplatelet agents data is not very clear at present. So there is no recommendation we can do for aspirin at least.
Okay. The next question is, steroids are given in severe COVID infection. Can it be given safely in people with hemophilia who have high titers of antibodies?
So steroids are in general can be given to hemophilics, but we should always know that steroid can cause a gastritis and all. So the treating physician should know that you have a hemophilia and they should maintain the adequate factor level. If you are receiving steroids, it means you are the candidate for anticoagulation, and you should maintain your factors level between 30 to 80% as I have described already.
Yes. So here it's not just the steroids. You're also going to consider that the patient who needs steroid will probably also need anticoagulation. So both the things have to be taken into consideration. Per se, there is no problem in giving steroids if you have antibodies, because at one time we used to try and use steroids, in fact, as a treatment to antibodies when we never had anything at all. So 1 minute, any other questions? This is a patient, she says she's a lactating mother of a 21-month-old boy and she has VWF. Should she get the vaccine?
So I think the UK Royal Society has given a guidelines, and according to them, those who are more than 6 months, 6 months from lactating and whose baby is taking outside food also, they can safely take it. And that is for the vaccines which are used in UK. Per se, the vaccines we are using in India and the lactating mother, there is no adequate data for that, as per my knowledge.
Yes, but I would also like to tell this person that if her boy is 21 months old, she shouldn't be lactating anymore. Right? She should have weaned him off by now. Okay. The next question is, can a person with hemophilia take the Johnson & Johnson vaccine?
So,
I don't know.
I'm not aware, because but they can check it, because Covishield and Covaxin only we are aware at present.
Right, exactly.
Madam, there is
So
one more
we'll
question,
stick to
madam.
whatever.
One more question. PWH with COVID with high titer inhibitor in ICU, how will you maintain factor 50%, and which one you will choose? Like, is a high titer inhibitor, that's what they mentioned in ICU.
So if the patient who is an inhibitor and he's not on imicizumab, so it is not recommended to give a thromboprophylaxis in them actually, because you cannot give a bypassing agents and maintain levels in them. If they are on imicizumab, then only a low dose standard prophylaxis only we can offer.
I think that's about it. The other two questions are not very relevant to this particular lecture. There's something about plasma therapy and hemophilia. Like I said, not relevant to this lecture. We will be taking lectures on basic treatment of hemophilia sometime in the next 2-3 months. So I hope you all will join in at that time and we'll be able to answer those questions. So with that, thank you, Rajesh. Thank you very much.